Good morning, everyone. Let's see what is behind the iris nodule. We have a 68-year-old man coming with defective vision in right eye for 4 months duration. Best corrected visual acuity was 636 parts and left eye was 6.6. Anterior segment examination revealed an whitish iris nodule extending from 2 o'clock to 5 o'clock with no surface vascularity. AC was relatively quiet and fundus examination was within normal limit. There was no relevant past history and UVA workup was done. On 1 week follow-up, hemoglobin was 8.2, ESR was 89 and MANDO was found to be positive. However, what we noticed that there was a sudden increase in size of the nodule with surface vascularity. We also noticed multiple small whitish nodules on the surface of the iris. For diagnostic confirmation, we went ahead with QTB and HRCT. QTB was negative and HRCT showed multiple nodules in lung with supraclavicular node and suggested biopsy. During this visit, we noted multiple new vessels on the surface of the iris with an elevated IOP. So we went ahead with biopsy of the supraclavicular node and to our surprise, it revealed metastatic adenocarcinoma and suggested immune IHC. Emergency oncology referral was done and they went ahead with PET-CT. Tumor markers except CA19/9 was negative and IHC report was pointing towards either a lung primary or an upper GI primary. PET-CT also revealed extensive metastatic disease with ocular involvement, hepatic and pulmonary involvement. Next generation sequencing was done to find out the primary and the final diagnosis came out to be metastatic adenocarcinoma stage 4 hepatobiliary carcinoma. We went ahead with palliative chemotherapy and while the patient was on chemotherapy, he came to us with a sudden visual decline. Best corrected visual acuity has dropped to counting fever 1 meter. There was total high fever and there was no fundus view. B-scan was done and it was within normal limit. Patient continued chemotherapy and during the chemotherapy, he came to ER department with sudden respiratory distress and finally the patient succumbed to the metastatic disease. So going to the second case, it's of a 68-year-old male who presented with redness in left eye of 2 weeks duration. He was treated outside with conventional treatment but was not responding and AC tap was done from the outside center. He gives history of TB. ATT was taken 3 years back and recent UTI. Left eye clinical image, showed a small iris nodule at 2 o'clock position with overlying fibrin membrane. Fundus B-scan was within normal limit. The lab reports were negative and aqueous aspirate analysis reports also came which came out to be negative. So we went ahead with HRCT, chest and abdomen which showed multiple granulomatous lesion. So a thorough systemic evaluation was done and multi-specialist opinion were sought to identify any foci of active infection, but all came out to be negative. Since the patient was not responding, we went ahead with the surgical procedure, that is the excision of the iris lesion. And on post-op day 3, the patient was doing well with best corrected visual acuity of 618. Inflammation was subsiding and the AC10 vitreous tap report came as negative. On post-op day 7, patient revisited, the AC reaction was getting better and best corrected visual acuity has improved to 612. During this visit, we got the histopathology report showing caseating granuloma, suggestive of a tubercular granuloma. On post-op day 14, he came with all the reports, vitreous culture, molecular testing and urine analysis, all of which came out to be negative. So on post-op day 16, the visual acuity was 6.6 parts. The eye was looking pretty well and the fundus was within normal limit. So the take-home message is that whenever we see an atypical iris lesion, it warrants metastatic evaluation and when in doubt, histopathology is the gold standard. So I'd like to conclude my talk by asking a question to the panelists, whether we should have started ATT in that case.
Thank you, Neethu. So we have 2 iris nodules, one turned out to be TB and one turned out to be metastatic. So first I invite Dr. Anuradha, how to differentiate an infective pathology from a metastatic iris nodule. Any key?
Okay. Can you hear me? Yeah. So you have a similarly aged patient, patient in their late 60s, presenting with what looks like very similar iris nodules in this case, but turning out to be TB and the other one turning out to be a MET. So the first case, what you should note is that, in spite of the lesion being there, the patient was asymptomatic. There's no AC reaction, there's no pain or redness, that itself is a big clue. The second thing I want to tell is, we sometimes should not forget our very basics, in that whenever we have iris nodules, you are suspecting a malignancy or a TB, you should look for cervical lymphadenopathy. And very often, doing a biopsy without doing an invasive procedure in the eye. Now, in this case, when it's in the anterior segment, it's relatively easy to biopsy the lesion, but if it's in the posterior segment, it's a totally different ball game. But if you can locate an enlarged lymph node, it might be pretty easy to get your diagnosis from that. And the third point is, whenever you have need to differentiate between TB and a malignancy, I think you should do HRCT in the first place, not the chest X-ray. I think those are the main points.
And the second question, whether a patient already treated with ATT before presenting with TB uveitis, when to consider repeat ATT?
I think in this case I would, because it's been a few years and you all know that TB can reactivate. Unless it has been a recent ATT, say in the last 2 or 3 years, and you have ruled out drug resistance, then in that case, I would not repeat the ATT. And you have ensured compliance and you have ensured that the patient has taken ATT for the recommended period of time, which is at least 6 months.
Yeah, drug compliance is very important. You have to take history again. And drug resistance, how to, whether it's pulmonologist decision or ophthalmologist decision?
So in real life scenario, actually, like when you clinically suspect TB, you have corroborative evidence. In the past, have taken vitreous sample and send it for drug resistant testing. But almost all the time it has actually come out negative. Negative even for TB. I think when it comes to ocular TB, it has to be the ophthalmologist's decision. So unless, clinically you feel, that it's progressing and you're suspecting drug resistance, I think most people nowadays would just, take the chance and then move on to immunosuppression. Yeah. Unless you are suspecting a frankly infectious tuberculous uveitis.
Thank you, Madam. Dr. Archana, you want to add any points?
I just wanted to add, but Dr. Anuradha already mentioned it, that you shouldn't be, rather you should consider as an inflammatory element, not just infectious reactivation. So yes, multi-drug resistant TB and with careful consideration along with the pulmonologist. If that's not the case, then definitely you should be considering like an antigenic inflammatory element as well, obviously treated with immunosuppression. Thanks.
Thank you. So to summarize, how to differentiate between an infective TB iris nodule from metastatic nodule. On clinical examination itself, you can clearly see, like, in metastatic cases, it will be like deposits, vascular deposits. There won't be any KPs and all. There won't be much AC reaction and all. And history taking is also very important, and those deposits won't resolve with topical steroids alone. And proper systemic evaluation, communication with the physician, with all these we can differentiate and we can save the patient also.